My journey in finding Lauren actually began with a Scleroderma Manitoba seminar that I attended on November the 14th. And at that time, it was a Jane McSwiggan. So she worked for the Winnipeg Regional Health Authority. And I contacted her after and I said, that was great. Do you know of somebody in BC? And she connected me to Shannon Handfield at the BC Skin and Wound Community of Practice Group, who then highly recommended Lauren Wolfe, who's a nurse that specializes in wound, ostomy, and continence. And I'm totally excited today to introduce our own BC Lauren Wolfe. As I mentioned, a wound specialist, not necessarily an expert in scleroderma, but definitely if you've got a wound, she's your gal. So let's talk a little bit about Lauren. She started her career nursing school, finished that in 1990 in South Africa, moved to Canada, and then she did a couple certificates, one in intensive care, and became a BC ICU nurse. And then she went ahead and got another one in 2006 of wound, ostomy, and continence. And then following both these, she established the wound, ostomy, continence nursing program at the Richmond Hospital. 2011, she moved into community nursing care. And then because there's just never enough education, in 2020, she got her master's of clinical science in wound healing at Western. She currently works at both VGH part-time and at the McDonald's Prescriptions. Some of you might be familiar with that pharmacy as a certified wound, ostomy, continence nurse. In her spare time, Lauren speaks at various conferences and publishes articles and posters helping in education. She volunteers at the United Ostomy Association and facilitates a 20 to 50s support group. She's an active writer for their magazine, The Vancouver Highlight. So just with this, and we're excited to have you. Thank you, Lauren, for joining us today. I will pass it off to Lauren to start.
Thank you. I'm really happy to be joining you today. And as mentioned, just know that I am not an expert in scleroderma, but I'm going to do my best and will be sharing with you everything that I've researched. And definitely, as you know, that I am okay in wound care. So I'm going to share my screen. Just give me a few minutes to share the right screen with you. Okay, Tiasha, is that, you can see the
Yep.
wound care?
You're good. Thank you.
Okay. So just of note, it is difficult presenting by Zoom when I can't see people. It's very difficult to present to a black screen. I do have a few of you that I can see, so it does help. It's always more engaging in person, but with COVID, we do our best. Now, you are all the experts in scleroderma, so I don't think I really need to go through the definition of this, but in COVID times, it is a good reminder that scleroderma is an autoimmune disease. And then from a wound care perspective, the importance here is that it creates a hardening and thickening of the skin, which often is what leads to the wounds. I thought I'd take a moment and share with you some of the wound care evidence. In my research, because I did have to spend many, many hours researching scleroderma, and what I was able to find is there is a lack of standardized wound care. It is very difficult in interpreting the evidence because every research study you read had a different interpretation of the wound care that was done. There was absolutely no standard, and therefore the articles always ended saying we need more research studies, which is something you find a lot in wound care, but it was very much evident in the scleroderma wound care evidence. There's reduced evidence supporting one therapy over another. And you're going to see a lot of variety in probably what I'm going to speak to today, as well as if any of you have wounds and then move on to being under another wound clinician, we will all do things a little differently due to the lack of standardization. And as I mentioned, all of the wound care suggested that larger studies are needed. And we know that the number of people with scleroderma is a very small percentage of the population. So that makes it even more challenging to get studies done because you have so many restrictions when you come to qualify to be a part of those studies. So, what is the prevalence and incidence of wounds in the scleroderma population? What I was able to find was that approximately 50% of individuals will develop digital ulcers. That means wounds on the fingers, sometimes the toes. And as mentioned previously, paucity meaning lack of evidence or very little evidence out there. Um, when it comes to scleroderma and wounds, but as well in general, it's very important for you to have a multidisciplinary approach. So when I look at wound care in general, whether I'm in the hospital, any type of wound, it's not always just what I do. It's very much looking at who can help me. So from a scleroderma perspective, it is absolutely essential, and you all know, and I'm sure you've all got a rheumatologist. The NSWOC, Nurse Specialized in Wound Ostomy Continence, or you in my title, WOCN, Wound Ostomy Continence Nurse. It just means I'm American trained versus Canadian trained. We are experts in topical wound care. However, what I have come to understand in reaching out to the scleroderma clinic at VGH is actually there isn't a wound clinician that is involved in that clinic. So that may be a little bit more difficult. Here I am now speaking to you and telling you I want a multidisciplinary approach, but you may not actually have access to all of these disciplines. And I would impress on you to ask for them. A physiotherapist to help with joint movement, your occupational therapist with contractures, and they do refer to an OT. I did check with them on that. A vascular surgeon if you're having any issues with vascularity, and then a plastic surgeon if it reaches the point where you may need advanced wound therapy. One of the other physicians that could be included is the infection control physician. And that is actually how I got linked in with the scleroderma clinic, was through a friend of mine who is the ID physician, and he was able to help me with that. So a multidisciplinary approach, and I probably have missed a few people here that may be important, but never think that you should be alone. And one other thing is you are actually usually at the center of a multidisciplinary approach. As the patient or client, you should be the one directing your care and which specialists you need. Looking at the skin changes, and I'm speaking to those of you who have scleroderma, and you probably know this already, but I always thought it's important to make sure that we're all on the same page. What happens with the skin is we get thickening and tightening, decreased subcutaneous fat. That means our fatty layer in the skin, loss of skin flexibility, sweat glands, and hair. You may get red spots from dilated blood vessels on the fingers, palms, face, lips, or tongues. It's a fancy word called telangiectasis, and that picture of that man's face is what it looks like. Discoloration or small white bumps under the surface of the skin, and we call that calcinosis. Wounds on fingertips, knuckles, elbows that are difficult to heal. When it comes to movement, you're going to find swelling or stiffness and pain. That may be on your fingers, toes, hands, feet, and face. And your sensation may be impaired with tingling, numbness, itchiness, puffiness, and again, restricted usually to the fingers and the toes. And this is just a little schematic of the skin. And when I'm teaching nursing students, I always like to remind them that your skin is not actually as thick as that diagram. Your skin is a couple of millimeters thick. So it doesn't take much to injure the skin. You're going to just see my daughter perhaps sneaking to get my cat. So if you hear her or see her, I do apologize because she's going to try and jump on me. Before we get into talking about wounds, I wanted to talk a bit about wound prevention because in my field, we don't want patients to develop wounds. We really want to prevent wounds from forming, whether it is a wound related to scleroderma, whether it is a pressure injury, which is more commonly known to the public as a bed sore. You'll never remove my job from me, so please don't worry about that. So, what can you do to prevent wounds? Looking at the different reasons for wounds, one is vasoconstriction. That means the vessels, and I'm going to go into more detail in the next few slides, but basically that's compression of the vessels. And that's because of smoking, stress, and temperature variance. Trauma, which is the joint contractures, fissures, you can do good hand hygiene. And then your autoimmune, that's probably the hardest part because that's your medications. If we look in more detail about hand hygiene, what can we do for that? It is absolutely essential to moisturize your hands, and that is for everyone. Not only for scleroderma will your skin be dry, but as we get older, our skin dries and our sweat glands get less. So it's important to moisturize every day. And I'll be honest, I'm not the best at doing that as well. But if you could put a tube of cream in your bathroom and every morning apply the cream. Also, when you come out of a shower or bath, it's very important at that time when your skin's still a little bit damp because it will absorb better. What are some of the good moisturizers out there? Most of the dermatologists and plastic surgeons like a very simple water based. We call that a Galaxol based. You can find it in any pharmacy. It's free of perfumes and contain and any ingredients that may be irritating to the skin. The Remedy product line, so those are the pictures, both the blue one, the Phytoplex, and the purple one. So the purple one is our basic moisturizer actually in the hospital system across British Columbia. And then the top one is more a silicone based, and we use it often for incontinence, but we do know that it's 20% silicone and it does provide a really good barrier to our hands. And coming back to one of the questions that was asked earlier in the week about how to protect your hands from all the frequent hand washing, the silicone cream is what the nurses are using now in the hospitals because of the frequency of the hand sanitizers and COVID to help protect the hands. So it would work really well for you with the frequent washing. One of my favorites, and I'll be honest, I don't have experience from a scleroderma perspective, but is a Manuka honey-based cream. I use that in my own personal life, often when my kids get a small burn or anything, because it's what's called antimicrobial, meaning the honey has the ability to manage some of the topical bacteria that may be present on your skin. It can be a little bit sticky when you first put it on, but if any of you do go ahead and try it, I'd be really curious to see what you have to say about it. For people with very dry skin on their feet, a urea-based cream is really good because that draws moisture from the environment. But if you have any open areas, it can sting a little bit. So do be cautious with that. When it comes to avoiding trauma, you can consider protective orthotics or fingertip coverings. And then it's very important. Everything I read suggested sunscreen. So please, in the summer, the minute that UV index gets up there, start using sunscreen. So what should you avoid? Well, this list got really long as I started to look in the literature. I did not get a lot from the scleroderma clinic, but it may be that I just didn't have enough time to connect with them once I got the information. The first thing is hot baths, so very hot water. And I would say that that includes when you're washing your hands, don't put it on scalding water. Lukewarm is okay. No scrubbing. So although it feels really great to scrub your skin, it's like a massage, please pat dry only. Antibacterial soaps. Now you're going to ask me at the end with COVID what to do about that, and I will address it at the end in a question. Please read the labels of the products that you're using on your skin. products like retinol, retinoid, retin A, vitamin C, alpha hydroxyl acid are all contraindicated when it comes to scleroderma because they encourage collagen formation. And in the scleroderma wounds, we have too much collagen being developed, and therefore we want to use products that minimize collagen formation. Other things that you want to avoid are fragrances, and then products called sodium lauryl sulfate. And there's a whole long list that, if needed, I'd have to go and find it again. Um, but you might just end up spending too much time reading the labels. And I would suggest, if you're very unsure, stick to a Galaxol based, because that one has almost no ingredients. It's very much water based. Um, all these others irritates the skin and interferes with the barrier function. In wound care, we believe in keeping things simple. The more layers you have, the more difficult it is to remember what to do. Other things that you may need to do is some lifestyle changes, which can be very, very difficult to do. It's easy for me to say to you, stop smoking, lose weight, don't be stressed out, but they're a little bit harder to do than what we hope. So, smoking in today's world, we've learned that smoking is a huge problem for vascularity. And it does narrow the vein. So, if you look at this picture, I'm not sure if you can see my arrow of the blood vessel. When you smoke, just like when it affects your heart, it does it to all the vessels in your body, and they start to narrow, decreasing the oxygen that goes to your skin. Vary in temperature, as I mentioned, vasoconstricting meds. So, what that means is medications that are also going to narrow your blood vessels. We want you to exercise, okay? And we want you to take nutrients. And I'll get into a little bit more about that afterwards. Now, I was able to be put in touch with an amazing vascular surgeon out in the US. And I was very, very encouraged to hear what he's been doing. Now, I have no experience with this, but he highly recommends this. Dr. Mark Mellon is his name, and he recommends a micronized purified flavonoid fraction. And it's a medication. Now, the one that he recommended, we can't actually get in Canada. However, in speaking with him, because I spoke to him for about half an hour, trying to understand all the amazing things he does in wound care, he runs a complex wound care clinic. And he said Vanixa is equivalent. I then checked in with the pharmacy I work in, McDonald's Prescriptions, and they do have it. And it's not a prescription medication, but as my pharmacist Jeff recommended, anytime you're considering adding any medications to what you're already taking, you should be discussing it with your physician as well as with your pharmacist. This medication can, I believe, drop blood pressure. So please be cautious with it. And I'm not recommending it unless you speak to a physician. When it comes to autoimmune, as I mentioned earlier, it's your medications, it's that connection with your rheumatologist to really make sure you're on the right medications for your disease process. And then from the trauma and prevention, you want to avoid it. You want to manage your joint contractures. So that's speaking to your physios, your occupational therapists, and avoid doing things that you know you shouldn't be doing, because repetitive trauma can really create wounds. And then please exercise. Now, again, we're in COVID times. I've probably gained 15 pounds because I haven't been to the gym. It is difficult, but even getting out there to walk every day is important. So now I'm going to move on to the things I know a lot better, and that is wound care. Now, I thought I'd give you a little bit of technical information about wounds and how wounds do heal, just to share with you the basis and for you to understand why wounds in scleroderma are a little bit more difficult to heal. When wounds start to heal, when you first get your injury of any kind of wound, our blood cells, white blood cells, gather to the wound surface to fight infection. And that happens for all of us. The next phase is what's called inflammation, and that's where the body's still fighting all the infection. We have lots of different types of cells coming to help out. Um, but it also means that if there's any what's called necrotic tissue in the wound, the body has to get rid of that. And I'm going to talk a bit more detail about that because that's oftentimes where the scleroderma wounds are stuck. If they move out of the inflammatory phase to what's called the proliferative phase, this is when the wound is on the healing trajectory now. We get the formation of collagen here, which then goes on to the scar and remodeling. And unfortunately, it's in these phases that we start to see some problems as well with scleroderma and the collagen formation. Looking a little bit more at the inflammatory phase, when you have an autoimmune disease, you have what's called increased inflammatory mediators, meaning your body is going to have a higher level of inflammatory response, which is not always a good thing because that can deter from wound healing. And what may happen is we start to see devitalized or necrotic or dead tissue in the wound. So if you look at that little picture there, I've got a lot of yellow tissue in the wound. About 50% of that wound, maybe 40, is yellow. That is not healthy tissue. We want to see red tissue in a wound. If you saw black tissue, that would also be a problem. So we want to get the wounds out of this inflammatory phase and into the proliferative phase. To do that, we have to get rid of all that yellow tissue, and we'll talk in more detail as we go along. With the proliferative phase and remodeling phase, as I mentioned, scleroderma patients have an increase in collagen formation. And so when you have an increase, you get what's called hypertrophic scars, so thickening of the scar. It may be difficult for the wounds to close properly. But as you know, when you do close the wounds, those scars are usually quite thick, and it's because of the increase in collagen. So as I mentioned, when you're looking at using products and creams and medications, you want to make sure that you're not adding to that collagen formation. So that's a little bit of the technical stuff. Now, looking at what would I as a wound clinician do to help a wound heal? And we call that the principles of wound healing. So anytime I get called to see a patient with a wound, I often have no idea what I'm going to find. I have little information and have to look at a lot of charts. And very often I'm playing detective because the first thing I need to do is discover the underlying etiology. So what caused that wound? Now, we're going to go into that a little bit more on the next slide because there are different causes of wounds in scleroderma. The next thing I'm going to do is a moisture balance and then removing devitalized tissue. I need to manage infection and inflammation, promote epithelialization, which is the closure of the wound, and part of this whole process is managing pain. So if we consider the underlying etiology specific to an autoimmune diagnosis of scleroderma, we can have 4 different types of etiologies. One could be a traumatic lesion, one could be calcinosis, ischemia, or digital fissures. The traumatic lesion is going to be located at a joint contraction on a bony prominence, such as the elbows, and it can be caused by repetitive trauma. Calcinosis, we know, is due to calcium deposits, and that's related to the autoimmune disease. Ischemia is due to the lack of perfusion. So we see this in those of you who have Raynaud's. It's usually the 2nd and 3rd digit. They're very painful, and they often require oral vasodilators. So that's medication. And digital fissures are small openings, and I have examples of these wounds that require moisturization. So this was a picture I found online just showing you a bunch of different wounds that could develop and what they looked like. So I'm not going to speak too much to that. We're going to go into more detail. So when we're looking at the wound presentation, what does it really mean? Like if I'm coming to look at you, you know, everything looks quite superficial, but it isn't always. So I thought it would be interesting to show the schematic of the differences, because remember when I showed you the picture of the skin, I said to you the skin is not as deep as what the picture shows with the nursing students. And this is a good example of that as well. If you look at the fissure, Tiasha, if you can just use your hand, can you see my arrow when I point? Yeah? Okay, so the fissure looks like it's fairly deep. Like this is an example. If we come back here, epidermis, the dermis, the subcutaneous layer. This is all about a couple of millimeters thick. So we're talking where you can barely see it. So if you think, got to go back up, the fissure is only through the epidermis, meaning that top layer of skin and just a little bit into the dermis. An abrasion, if you want to think about falling off your bike and skinning your knees, that's the level of an abrasion. And then the skin also start superficial and can get deeper. So they can be as thin or as shallow as the epidermis and go all the way down to the fat layer. And in some cases, all the way down to bone or muscle. Okay. And that's something that we're going to look at as wound clinicians is the depth of the ulcer, because by the time it starts getting to the muscle and the bone, we're getting really worried. When it's just a fissure, I know that I've got less chance of it being a large, big wound, and this is my chance to try and close it using moisture. So digital fissures. The etiology, as I said, is moisture. So again, COVID times right now, all this frequent hand washing, it's really important to moisturize. Many people, diabetics, people with just very dry, thick skin, people who work outside a lot, get fissures frequently. And often when they've developed, it's very hard to heal them. And if you do heal them, you often find they reopen in the same places. So moisturizing, preventing, all of those are incredibly important to stop these fissures from occurring. This is an example of a wound that's located on the knuckle or the joint from trauma. Now, when we talk about trauma, oftentimes you think that it's because you keep hitting your knuckles against something. This is actually trauma as well from the inside. Just from bending your knuckles frequently over and over with swelling can cause pressure and trauma on the skin. And you're going to say to me, but Lauren, how do I prevent that? It is very difficult. And again, I'm going to go back to moisturizing, trying to get the swelling down. And we can talk a bit more about that as well in the chat. When it comes to ischemic lesions, as you can see the difference where the others were located on the knuckles, these are located very much on the fingertips. These wounds look small. Very often people minimize wounds that are small like this, but don't look at the size of the wound. Look at the depth of the wound, because the depth is telling me how severe the wound really is. If this wound is just through the epidermis, like an abrasion, I'm a little less worried about it. But if I'm now starting to look and see that I've got some dead necrotic tissue, yellow or black in it, that tells me I'm already into the fat layer. And if I can feel bone, then it's concerning me even more, because when you have a wound that what we call probes to bone, there is a 80% chance that you have a bone infection. So very important, because we want to prevent those bone infections because they're not good. You have to go on heavy duty antibiotics for those. Calcinosis. Now, this picture scared me, I'll be honest, because there are a lot of little calcium deposits in this wound. And these are not something that, looking at a picture like this, that I as a wound clinician could remove. If the wound was open and I can see the calcium deposits, I may be able to try and pick them out, but this would require referral to perhaps a plastic surgeon who would be able to remove these if they were causing problems. These still look like they're very much under the skin, so they may opt to leave them depending on how painful they are, but eventually they're probably going to break through the skin and cause a big nasty wound. They don't dissolve and go away on their own. Now, interestingly, as I was doing a lot of my research, and there was an amazing paper by a wound ostomy clinician in the US, and what she said was that the WOC nurse, which is me, may be the first to identify those calcium deposits in the wound base. And I think it's because Scleroderma wounds are very much not known to the average nurse or to many physicians out there. Like wound care is so vast in all the different types of wounds. If you just go to your GP and say, "Oh, I got these bumps," very often they think gout or they start thinking other things, or they just go, "I don't know what it is." So now you guys are going to know ahead of time. And if that happens to you, you're going to say to your physician, your GP, "These are calcinosis, they're calcium deposits. Send me to a wound clinician." General principles of wound management are pivotal to healing these wounds. Your wounds, despite, as I keep referring, they are small wounds but deep wounds. They require a specific type of management. As I said, calcinosis cutis is difficult to treat and usually requires surgical excision, meaning I would have to refer you to a physician who can surgically remove them. Okay, so now we've got a wound. What do we do? Well, this is what we do for all wounds. The first thing is promote moisture balance, um, debride the wound, meaning remove any necrotic tissue. If there are calcium deposits and it's a wound that is open, I'm going to try and remove them. Manage infection, inflammation, promote epithelialization, revascularization, and pain. And you're probably saying, "Lauren keeps saying this and she's not showing me how to do it." I'm going to go a little bit into some details and we're going to talk more as we get to dressings. When we're looking at what it means to create a moisture balance, it literally does mean balance, meaning not enough moisture is not good and too much moisture is terrible. So if your wound is dry, like, and starts cracking, add moisture. If it's too wet, you got to absorb it. What we use, a saying we use in wound care a lot is not too wet, not too dry, like the inside of my eye. So if you think about your eyeball, and don't tell me you're somebody who has to add eye drops because then it's not right, then you're too dry. But that's exactly what you would be doing. You're adding moisture to a dry surface. It's just which moisture, and that's the type of dressing that we would help you choose. So we don't want that dry wound bed. Macerated peri wound, that means if you ever lie in a bath full of water and your fingers go all white and wrinkly, that white tissue is macerated tissue. Your body has absorbed moisture and it's too wet. After a few hours, it dries out. But with a wound, if the wound keeps exudating moisture, the area around the wound keeps getting wet. So it's selecting a dressing that actually will absorb that moisture to prevent the wound, the skin around from being too wet. We need to manage pain. And it's important. Why is it under moisture balance? Because when a wound isn't in the right moisture balance, the wound may be more painful. And I need to choose the right dressing that's going to decrease pain, create a moisture balance. Um, when there's too much moisture in a wound, I may increase the size of the wound because that white macerated tissue becomes unhealthy and the wound gets bigger. And so, for both of these, whether it's dry or whether it's wet, I'm going to delay the healing of the wound. And it's finding that right wound balance. Okay, so the next thing I said was debridement. So, how do we do that? That is, firstly, it's the removal, as I keep saying, of devitalized tissue. It is varied in the international community on how that is done. So, just of note, a wound ostomy continence clinician or a wound clinician can remove necrotic tissue using a scalpel, but they cannot cut into healthy tissue. Right. So if we're needing to cut into healthy tissue, we are going to send you to a plastic surgeon or a vascular surgeon to do that. A bedside nurse or your average staff nurse may not do that. Okay. So the first thing I'm going to do with removing necrotic tissue is I'm going to use my dressings, because if I create that moisture balance, that topical wound care will technically dissolve the necrotic tissue. Um, we call this healing by secondary intention. Other ways in the long run, after we've removed the necrotic tissue, we've got a healthy wound base, you can have a skin graft. Okay. I've written here can aggravate the healing process. So if we don't choose the right dressing, you may find that we are aggravating, as I said, the healing dressing. So if my dressing doesn't absorb the right amount of moisture and it's too wet or it absorbs too much, I'm going to delay healing. And again, I cannot heal the wound with devitalized tissue or calcium deposits. If gangrene is present, so gangrene is black tissue, right? It's a scary word, and you can get dry gangrene and wet gangrene. Dry gangrene is when it's on the fingers or the toes and it's very dry. Wet is when it's all mushy. And as I mentioned, it's a scalpel. Curette is just a circular scalpel, and it's either somebody, a nurse that is trained in that, or it will be a plastic surgeon or vascular surgeon. When we're looking at dressings, and again, I will go into a bit more detail, the types of dressings that we are going to be considering is a collagenase. Now, collagenase doesn't mean collagen in this case. This collagenase is a urea papain base, and it actually eats away at the necrotic tissue. Pleura Gel is a newer dressing on the market. It is a gel, and we found that it does help to manage any bacteria. And, we call them biofilm, which biofilm actually is the same as plaque on your teeth. The plaque on your teeth is a biofilm, it's a little colony of bacteria. And the reason you go to the hygienist to scrape it off because it doesn't come off with just regular brushing. And what we found in wounds is we get biofilms as well, and we can take them out using a scalpel curette. But we're starting to see new technology, and Pleura Gel is one of the dressings that is able to manage that. And then, as I mentioned earlier, creating that moisture balance will also help to melt the necrotic tissue. Um, Really important when we're looking at choosing the right dressing is management of inflammation and infection. And again, we do this by selecting dressings. There are a number of different antimicrobial dressings on the market that we could consider depending on your wound presentation. So, what are the signs of infection? This is very important for you to know because when you start to see 2 or 3 of these signs, you do want to seek medical attention. So advancing redness. So if you look at this picture, this red looks sore, right? It's not located just near. I'm using the wrong one, I think. It's not located just near the wound over here. This redness is actually spreading all the way up up the finger. That is concerning, even possibly to the second finger over here. Pain. When your pain changes for the worse, so it gets worse, pain can be a sign of infection. Swelling, pus, heat, and warmth. And what we often do is topical antimicrobial dressings. So our topical antimicrobial dressings are silver dressings, honey, hydrophora blue, the Pleura gels, iodine-based dressings. There are a number of different ones, and we're going to select those based on the wound presentation, the form and function of the dressing, as well as any of your other comorbidities, because there are some of these dressings that can't be used with certain medications or other diseases. And then antibiotics. Never let's forget antibiotics. Usually when an infection like this finger is spreading like that, you will need to go on to antibiotics. Coming back to that moisture balance, so in order to promote the closure of your wound, once we've got it beautiful and red, the tissue, we need to make sure we still have that moisture balance because the cells that help to close the wound from the edge of the wound need moisture in order to heal properly. And if you look at this picture, more the schematic at the bottom, you've got this wound over here with dressings. You've got this very, very dry wound. What happens as they close over this top layer here of cells, leapfrog over each other when they have a moisture balance, and all the factors are in harmony in your wound to go ahead and close the wound. And wounds always heal from the bottom up. So just to explain, if we're looking at this wound here that looks quite deep, again, we're down into the dermal layer here. What you notice is you've got a bit of a cavity. That wound isn't going to leapfrog over the top here. It's going to close from the bottom up. And that's what we want to see. Otherwise, we run the risk of very deep wounds of creating an abscess. As I mentioned earlier, pain management. This was just a slide to talk about that. So, looking at the dressing, there are many dressings that we have on the market that are what we call a non adherent. So, there may be a silicone or petrolatum and have like a Vaseline layer in them to help decrease the pain when it comes to dressing times. If the wound bed itself is having pain, we can speak to the physician about different topical medications that we can apply to the wound bed, or you need to take analgesic before wound dressing changes. So many, many options. And actually, it's a lot of these on my next slide right now. So when we talk, as I said, pain management during dressing changes, debridement. No one should remove necrotic tissue from your wound if it's going to hurt, right? You need to have analgesic pre that. So usually when a wound clinician debrides, because we're not allowed to cut into healthy tissue, we usually don't cause pain, but these wounds are very small. So really grabbing onto that necrotic tissue may be a little bit more uncomfortable. And it's something that anytime somebody's debriding your wound, you have the right to say, stop, this is hurting me, and the non-adherent dressings. So as I mentioned, some of the dressings, looking at, I mentioned the silver dressings. A lot of those were the antimicrobial dressings. Other dressings we use are alginates, also hydrofibers, not on the list. Those absorb moisture with, they don't have antimicrobials. The honey is an antimicrobial. I mentioned the Pleura Gel and the collagenase. And then there was one study that actually mentioned a vitamin E. Now, I know of vitamin E cream, but I'm not aware of any vitamin E dressing products. And most studies won't give brand names. So I'm not sure if this was something that's available in the US and not in Canada. There was a lot of talk about advanced therapy options, surgical options being skin grafts, skin flaps, that type of thing. Npwt stands for negative pressure wound therapy, which is basically a suction attached to a machine. Acoustic is water based, mist is a form of debridement. Then there were some studies using stem cell and bioengineered skin, shockwave therapy, which I know a little bit about, UV light. Now, UV light was really interesting to me because, as Michelle mentioned, I just recently finished my master's, and UV light, UVA was one of the therapies that we did look at. And so I reached out to my professor to ask her if she had had any experience with scleroderma patients, and she hadn't. Now, it may be because the machine is very big and the scleroderma wounds on the fingertips are very small, and you do need to protect the healthy skin around. And therefore, it may be a different modality, difficult modality to use on small wounds. But it was very interesting because she actually is an author or co-author of one of the papers I was looking at. So definitely something that brought some thought to mind. And then HBO2, which is hyperbaric oxygen therapy. And then there's a new therapy out there, which I don't think has been used on scleroderma wounds yet. And it's called EO2. And that is direct application of oxygen to the wound. And it's still very much a controversial therapy, as many of these advanced therapies are. So I had to do the honeycomb just for that. So honey, honey has really made a comeback over the years, but please don't go and buy honey from Costco. It is a medical grade Manuka honey. I'm coming back to all the same products that I've mentioned before, the Pleura Gel, the alginates, the collagenase, the vitamin E, and I will open it up for discussion because I think it will be easier to talk about the dressings in a discussion format. What I did want to show you, and I think I'm going to try and do this afterwards, Michelle, because I think the YouTube is going to mess with the screen share, is how to apply a finger dressing if people don't know. So coming back to the advanced therapies. So just want to mention that there were limitations in these studies on the sample size or study design. Remember going back to my first slide, I said there was very limited evidence and small samples. There were 5 studies that demonstrated what iontophoresis could increase blood flow. I had to look that up. I did not know what that is, but what it seems to be very similar to a wound therapy we use called e-stimulation, which is ion based, so electricity based, but using a different machine. I am not aware of this being done anywhere in Canada for any kind of wound care, though. I would be curious to know if Easton would work on these kinds of wounds because we can use it on arterial wounds, and it has shown some improvement to arterial wounds. And again, going back to my master's, the head of the program is that is her baby, Easton. So I haven't reached out to ask her about ionotophoresis, but it sounds very similar. And then with the advanced, no single modality was demonstrated to be superior to the other. It seems to be very much dependent on the individual, and everything going on with you. Now, when it comes to wound care, we cannot forget about nutrition. Nutrition is huge. If you don't eat well, your wounds will not heal. So Dr. Mark Mellon, I mentioned him earlier, he shared with me his cocktail. This may meet a little bit of resistance in British Columbia because I did show it to one of the dietitians at VGH, and she had a little bit of concern saying it hasn't been demonstrated to have wound healing properties. So I did then email Dr. Mellon back, and he said there is newer evidence. So please discuss this with your GP. I am aware that vitamin D, especially in BC, most people are very low on vitamin D. Vitamin B12 as well is very much one of those vitamins that we don't get enough of. Folate, well, I can guarantee not everyone's eating their leafy greens. L-arginine alone or as part of Juven. And now I knew Juven had come up for me recently, and I'm treating a wound care patient, totally different reason for her wound. And she takes Juven. It's a dietary supplement. And then vitamin C. Now, the vitamin C, I do know I would want to question that a little bit more I know it can maybe increase scarring, but Dr. Mellon does actually treat scleroderma patients. So part of me says I want to go with him. He's running a big clinic. And then vitamin D if you're having prednisone, and they do a 10 days of a standard dose. I'm going to go back to that research. Guys, we need more research. So we need your help. I don't know of any studies out there, but if you do hear of studies, when it comes to wound care, please, we'd love to be able to come up with a modality of a great regime for wound care. But right now we don't have enough due to the lack of research. So in conclusion, what I want to say to you is that when it comes to skin, please keep it well moisturized. You need to check your skin daily for fissures. So you want to check your hands, you want to check your feet. If you can't check your feet because you can't reach them, put a mirror on the floor, put your glasses on if you can't see without them, and have a look in the mirror, or see if you've got a friend or family member who can help check your feet. If you can't do it daily, do it weekly, but don't ignore it. Make sure your shoes fit you well. Tasks, use caution during daily tasks like gardening, cooking, or even opening mail to avoid skin cuts. And then regular exercise and physical therapy will help to keep your joints more flexible. I just wanted to share with you Dr. Mark Mellon's credentials because he really did help me a lot in understanding his cocktail for wound healing. I'm going to take a minute to just talk about the questions that were submitted before, and we can discuss them in more detail if I haven't answered them correctly. So one of the questions was, how often should I change a dressing? There is no time frame. It's really very much wound dependent. It depends on the location of the wound. It depends on the exudate. So whether it's too dry, too wet. There are so many factors. Most wounds we ideally want to keep a dressing on for around 2 to 3 days to create that moisture balance. But if the wounds are on your fingers and they're getting wet all the time, then no, we want you to change them more frequently. So it will depend on your wound care plan that's been provided to you. What can be done to prevent scarring? For scleroderma wounds, it's an increase in collagen, which is part of the disease. There unfortunately is no evidence that I was able to find on how to prevent it. However, when you look at treatment, you could consider scar therapy like ScarAway or Mederma, BioOil, Biodermis. Now, these I've only shown evidence on regular wounds, people who develop scars, uh, but they do say they are available for um, hyper, hyper got to think now, hypertrophic scars. However, no one talks about scleroderma in particular. I definitely would give it a try. However, it does take a long period of time for any scar therapy to work. And do know it is an expensive way of doing it. So it just depends on what the scar means to you. If it is over joints, I would say I would definitely give it a try, because over joints, you're going to get contractures happening. How should I keep my calcium extrusions, which is calcinosis, cleanly bandaged? Very tough, as I said, right? So challenging when doing washing, etc. Try putting large dish gloves over top, wear finger cuts. I do need to go back to that slide to show you that one. Um, Try to protect them if you can. It is a challenge, but the idea is to wear gloves to help keep them clean and dry. Is there a product or way to protect the ulcers on the fingertips with all the extra hand washing and sanitizing, especially with COVID? So again, the finger cuts. And you'll see here I've said minimize hand washing by wearing the gloves, dressings that are more occlusive. So some of the dressings more occlusive out there are products called Duoderm. They are hydrocolloids, but everything I've read, like I rarely use hydrocolloids in my practice, but people do use them for the occlusiveness. All other dressings are semi occlusive, but a lot of people will use the hydrocolloids to be occlusive. You just want to be careful that you don't create too much moisture under those dressings. So, again, I'm going back to wearing gloves, which I know is not ideal. You go to the bathroom, you want to wash your hands. You're going into stores, you want to wash your hands. So I reached out to Dr. Hayak from ID. I told you I have a friend, um, and asked him what he suggested because of COVID. And he just said, use lots of moisturizers regularly after hand washing, wash with soap and water or with alcohol hand sanitizers. And it's interesting, he's saying soap and water. He's not saying antimicrobial for everything. And we know that the antimicrobial soaps and hand sanitizers really dry your hands out. So soap and water is absolutely fine if you wash your hands properly. How can a person live with scleroderma hands prevent wounds from evolving into ulcers? So pretty much I discussed this in the presentation, in that moisturizing is key, exercise is key, nutrition, avoiding too much activity. So when I spoke to Dr. Mellon a little bit about this, he really said if you don't need to be doing things, if somebody else can wash those dishes for you, make them wash the dishes for you. Okay. So take care of yourself. Put yourself first in your home. Is there a way to prevent bacteria from getting trapped in digital ulcers to prevent furthering the infectious process? Again, staying healthy. It's very important to be nutritionally healthy, exercise, and then correct wound management. What steps should someone take who is on oxygen and is taking blood thinners with a minor injury? I was a little confused about this question, I'll be honest. Oxygen is not a problem for wound care. Blood thinners, you will bleed a little bit more. You're going to, if you knock yourself or create a wound and it's bleeding, you are going to need to apply pressure until the bleeding stops. If the bleeding doesn't stop, you will need to seek medical attention then. But I wasn't really sure what the individual was asking me there. Stasis dermatitis is not usually something that I've read related to scleroderma. It's related to venous insufficiency. We see a lot of this, and you could have this with scleroderma. Like I'm pretty sure that patients with scleroderma don't only have wounds related to scleroderma. You could get other wounds. So perhaps this individual has wounds related to stasis dermatitis, which means that you have venous insufficiency. So what's happening is the blood is pooling in your legs and you're not getting enough oxygen and nutrition to the tissues, which is then leading to a wound developing. So the first thing we want you to do is elevate your legs. We want you in compression therapy, calf muscle pump exercise, which means basically standing, holding onto a surface, so a desk or a table, and going up onto your toes and then going back down again. We want you walking, weight control, and then really gentle cleansers and moisturizers on your skin. All right. So what I'm going to do is just go back to that slide quickly on the, and see if I can do it without totally messing up the presentation.
I'll just say, Lauren, if it doesn't work, you can always send us the link and we can share it with folks afterwards. So if you have any issues, and I did receive a few other questions to ask you once you've given this a shot.
Okay. Which, are you seeing anything right now?
No, I'm not. So you might have to stop sharing your screen and then try sharing again with the where the video is.
Okay. All right, so this, just of note, this is one company's dressing. It doesn't mean everyone needs to go and buy Meplex Border Light. Any of the company's dressings could do this. I tried to find what I thought was the best video possible. Not sure. Let's have a look and see how it works.
We can't hear the sound. I think you need to share the sound on the bottom of your screen.
You know what? I'm okay if you don't have the sound, because it's more about the application, if that's all right.
Great, no problem.
She does have pretty fingers. I just want to stop it there for a moment. Note, and I'm not sure if you can clearly see this, but the she's put, or he, I think it's a she's put the dressing on a little bit further down, not exactly in the middle. I'll try and show you a bit as it goes, try and show that more clearly. No, okay. Over there. I don't know if you can see how they've cut it over here, that in fact the cut is mostly on the finger and then this wraps around. It will probably take a little bit of practice to get this right a few times. Now this dressing, I find if you get it right the first time, it definitely will stay reasonably free of getting moist. However, it is a semi-occlusive dressing, therefore I cannot guarantee that it will not get moisture in it if you wash your hands a lot. I'm just going to move my screen because I feel like I'm looking up. I've got to get rid of this.
Okay, well, thank you very much for your presentation. I have a few other questions. If folks still have time and would like to stay on the call, I will bring those questions to Lauren, and then we'll stick around afterwards for a really, really quick survey before you head out. So one of the questions I received was, do you have any recommendations about how someone could dress pressure sores on their buttocks?
Okay, so firstly, pressure sores, new terminology, pressure injury, doesn't really change the management. Just like scleroderma wounds, you have to remove the pressure. So if you've got them on your buttocks, as long as we're talking buttocks, it's usually because they've happened when you are in bed. But you do want to be clear, because sometimes people confuse their, they call them sitting bones, the seating bones. When you're sitting in a chair, if you put your hand under your bottom, you'll feel bones there. And those are from sitting in a wheelchair for long periods of time. So if the wounds are sort of, you put your hands under your bum, when you're sitting, those are actually from sitting. If they're higher up on your bum, then usually those are from lying in bed. Take the pressure off. The same principles that I talked about today about moisture balance, debridement of tissue, all of those will work the same way. But in order for wounds to heal, the cause has to be removed. So I can tell you many different dressings that will work, but I'd need to see the wound to know the moisture balance, to know the necrotic tissue in the wound. And I'd need to know that we are taking the cause away. So you're probably saying, well, if they're caused by bed, I can't take my bed away. Where am I going to sleep? Usually when they're on your bum, it's from lying on your back. So start by lying on your sides. Even if it's 30 degrees, which is where we put you in hospital, a little bit of an uncomfortable way to sleep at 30 degrees, you can curl up on either side as well, but stay off your bum. If you're somebody who sits in an easy chair or sleeps in an easy chair, it's your chair. You need to change positions every 2 hours. Does that answer the question?
I think so, yeah. So another question we received was, in your research, did you come across any scleroderma cases where the wounds would indicate amputating the fingertips?
Yes. So when you get necrotic, so when the circulation, especially from Raynaud's, becomes so severe that your fingers or your toes are totally black, and the circulation has been compromised, that there's no longer any blood flow, which means no oxygen and nutrition to those areas, they will need to amputate those. Sometimes, and it may sound a bit strange, they'll leave them all connected and let the body do what's called a self-amputation, meaning they will fall off to where the circulation is healthy instead of taking you to surgery, and taking them off. So my goal would be, as much as I can, is to try and help all of you to prevent that from happening. We can never always prevent everything, but that's the goal of trying to get you seen before your wounds get to that point.
And Beth has a question. She's wondering if you've heard anything about a treatment regimen called, and forgive me if I'm saying this wrong, Iloprost, and whether it's available in BC.
No, I haven't. I'd be curious to know what it is.
Beth, do you want to unmute yourself and if you have any more information?
Hi. Yeah, I just heard about it actually on the weekend, or maybe a couple of days ago. I was chatting with some friends who also have scleroderma, and they, one of them is from the UK, and she has had, and I think it's an infusion of some sort, and you have to, in the UK, you have to be hospitalized because it's they keep you overnight, and I think it's sort of 5 days, and it's an infusion. But she said that it just makes an incredible difference with the circulation in her fingers, and that it essentially takes away her Raynaud's for 6 months at a time.
Yeah, because I'm not an expert in scleroderma, I'm not going to be aware of any of the medications that are related to that. The first thing I would suggest you do if you want to look into it is go to the Health Canada website, and try to find where medications are approved, if it is available in Canada. Because everything has to go through Health Canada for approval, even a lot of our wound care products.
Okay, and I think that covers it for now.
Sorry, I did open the chats quickly, about the wrinkly skin.
Oh, yes, thank you.
So you mentioned with skin as being too moist. What about wrinkly? Wrinkly is not a problem. Wrinkly is old age, but if it's wrinkly and dry, you do need to moisturize. This is the sole or heel, which is painful already, but now is a small sole. Looks like pics of ischemic ones.
It's
Moisturize.
wrinkly like after a bath. That's that sort of
Oh,
wrinkly.
okay. Sounds like it's a bit too moist. Using polysporin or diclofenac. So diclofenac's an anti-inflammatory cream, I'm assuming, and polysporin on a non-adherent pad. It sounds all a little bit wet. Very difficult without a picture for me to totally see this wound. I'm not a fan of polysporin. I'll be honest. Polysporin is, I think I want shares in the company because it's the first product that everybody jumps to. But it's got antibiotics in, and as wound clinicians, we believe in antimicrobials versus antibiotics. A lot of people do still use it more for facial wounds because some of our products create staining if we put them on the face. Short-term staining, but still staining. But it sounds like this is very wet. And again, I would question, why do you have a wound on the sole of your foot or on the heel? Check your footwear. Look at the cause of why you're getting that wound. It could be, I didn't read a lot of scleroderma wounds on heels. I read about them on digits, a little bit on the lower leg. But I think something in your footwear may be not totally right. And then with the compromised circulation, it's causing a pressure injury is what it's probably doing. And then topical, I don't know what dapsone is. Again, I think you're using medications on topical wounds and trying to treat wounds. Is that right? For Eric?
Oh, yeah, I see a thumbs up.
Okay. A lot of taking medications and using them topically is a little bit off label. So in my practice, I have to follow wound care principles. So I have not used that. I haven't used aspirin in wounds either. Take aspirin for cardiac reasons, but generally don't do aspirin for anything else. And then Gerlison, I'm not sure that cream. Urea, if it's got urea in, absolutely. It's drawing moisture from the environment to help moisturize your skin. I mean, there's a number of brands on the market as well. There's Attractane, there's Uramol with different levels. But if you do have openings, it will sting. It's not a problem if it stings, but it can deter you from using it. I'm not sure what the graft versus host disease question is.
I'm not sure either.
Okay. One of the things wound care is challenging, and I would really encourage everyone to take care of themselves and seek the help you need. All right. Vancouver in particular, Vancouver Coastal, we have a huge number of wound clinicians around. All our community agencies in Vancouver itself have wound clinicians associated with them. If you're moving out to Coquitlam, Fraser Health, Interior Health, a little bit less, but there should be access to wound clinicians. And then there are a few of us who do have private wound care practices, but I always recommend people as a first line is go to your community and get help for your wounds, and don't let them trivialize the wound, and know that they don't understand scleroderma, because I really didn't understand scleroderma until I started to look into doing this presentation. So thank you, because I think it really has changed my practice when I now go and look at wounds. We always take histories, but I don't think I really understood the extent to which you develop wounds. And on a personal note, my daughter does have Raynaud's. She doesn't have scleroderma, but she does have Raynaud's. So this has really been helpful to me as well.
Well, thank you so much for your time, Lauren. I'm just aware of how long our presentation is running at the moment. And I just wanted to share with everyone that, so I do have a very short poll I would like for everyone to fill out. It should only take you 2 minutes. It'll pop up on your screen. I'm also about to share a message in the chat. So if you have any ideas for future presentations like today's session, we would love to hear what your suggestions are. We can't promise that we'll be able to find a speaker to speak to them, but if you enjoyed today's session, and we'd love to hear your feedback on that. So I will present a poll shortly, and I'm going to stop recording.